Matters with Dr. Julius Gilead. Remember, you can watch us live on Facebook, live on YouTube, and also live on X.
Rev-Up St. Lucia is located at Unit 4, Gablewoods Mall, Sunny Acres, Gas Street, St. Lucia. Tune in on 95.9 FM or online at revupslu.com. Call the studio at 572-9710 or WhatsApp 287-0971. Call the office at 572-0383 or 572-0215. Rev-Up St. Lucia, the alpha of radio.
Time now for Mind Matters with Dr. Julius Gilead, brought to you the compliments of Foresight Mental Health Solutions located at Tapio Hospital. Dr. Gilead, welcome once again. It's good to see you.
Thank you, Andre. Always good to be here.
Thank you very much for being here.
And good morning, St. Lucia. Welcome to another episode of Mind Matters. And today we continue to have our mental health conversations out of the clinic, out in the community, wherever. And I am your host, Julius Gilead. Today we're diving into a phrase that lies in the heart of psychiatry, and many people have never even stopped to think about it, and that is psychiatric diagnosis is a diagnosis of exclusion. Yeah? So that sounds like medical jargon, yes?
Mm-hmm.
And what it really does mean is that before we say someone has a psychiatric illness, like depression, anxiety, schizophrenia, or bipolar disorder, we must first exclude all other possible causes. So physical causes, social causes, psychological causes. And in psychiatry, diagnosis is not based on a single test. So we cannot take an X-ray for schizophrenia or a blood test for depression. That's not done in psychiatry. Everything in psychiatry is, or most things through psychiatry are done through observation, through conversation, and investigation. So we ask, could this person's anxiety be caused by thyroid disease, which is a major cause of anxiety? Could their hallucinations be caused by side effects of steroids, or by them using some substance that they used at a party or something? Could the anxiety stem from trauma, or the depression stem from trauma or chronic stress rather than a brain disorder? Now, one of the things about psychiatry is that in the olden days, it was actually linked to neurology. And there was eventually a separation of neurology and psychiatry, because psychiatry is a brain disease. It's about brain diseases. And neurology is all about the brain. Yeah? So with that separation, that's where you had all of those disorders coming into play. And even along that line, I was having a discussion with somebody just this week, and the person was asking me about disorders versus illnesses. And I remember I mentioned once that I only treat disorders, and that's when the person is distressed and disturbed by their symptoms. So if there's no distress and no disturbance, then I don't consider it a disorder, because disorder means that there's disequilibrium.
Dr. Gilead, you made a very interesting observation. You said that when it comes to issues of mental illness and so on, there's no blood test you can take to determine what's going on. Why is that? Why is that? I mean, because with all the advances that, science, why have they...
So we have to first look at the brain. So the brain is a very unique organ. The brain is made up entirely of nerve cells, and those nerve cells are supplied with blood, which then has to pass through something called a blood-brain barrier. Before anything gets to the brain, it has to pass through a barrier. So it's not like the other organs which are directly, blood goes directly to them. So you have no barrier. All you have the only barrier they have are the blood vessel barriers. But with the brain, there's a blood vessel barrier, and there's something called a blood-brain barrier, which is another barrier which the substances now have to go through. So the brain then decides what comes through it and what leaves it. And the brain, there's no blood tests per se. I think the only direct method of knowing what substances are in the brain are from doing a lumbar puncture. So you took out some fluid from the central nervous system, from the spine, because the spinal cord is connected to the brain, and the fluid there flows into the brain. So you take some fluid from there, and you can see what that's composed of. So the pressure it comes out with, what it's composed of, etc. And so there's no way of saying somebody with depression has these markers in blood, because that's not so. The scientists are now starting to discover changes in the spinal fluid, and even markers that were not noticed in blood or in the DNA or other aspects of the body, which can be used to suggest, and again it's a suggestion, it's not like the other illnesses where an X-ray will say there is a pneumonia. It's a suggestion. So they're suggesting that this may be linked to that illness, or that may be linked to this illness. I think a lot of our work is going into dementia, because dementia is a long-term chronic illness. Unlike things like depression and anxiety, which come and go, they're episodic. So dementia is progressively deteriorating, but depression and anxiety are episodic. Bipolar illness is episodic. Schizophrenia can have, although it's a long-term deteriorating illness, but it does have its acute episodes as well. Yeah, so very interesting, and I guess there's still a lot of work being done in that aspect of psychiatry, and a lot more to come, but we're still at the start of that.
I don't know if you mind sharing with us, you said from observation and so on, how do you get to the determination that there is a mental issue?
So that we'll get into in a little bit.
Okay, no problem.
But what we have to keep in mind is that sometimes people are probably given labels when the real problem is elsewhere. And it's something I've been trying to stress from the time I came back from my studies. We cannot just say somebody has a psychiatric illness without doing lots and lots of tests to rule out other things. And sometimes when persons come to me and I give them the list of tests that they have to do, they groan and complain because they may not have the money to do the tests and so on. But we don't want to be treating something that it's caused by something else. So for example, somebody with anxiety, you give them anti-anxiety medication, and it can actually worsen the anxiety or can cause other issues, whereas the issue may be thyroid disease, which is treated simply with the medications for either hypo or hypothyroidism. Just recently I had a patient of mine who I've been seeing for a few months, who never told me that she had a long history of thyroid disease long ago, and she was having flare-ups of her anxiety, and she just remembered that's how she used to feel when she was initially diagnosed with thyroid disease, and she had to have it checked out. So we have to look at the medical issues, the medical aspect of the person first, and then we can consider that the person has a psychiatric illness.
So basically you're saying we, as people who are untrained, should not be the ones determining whether somebody
the who they go to
has a mental issue. Because it's true. In our culture, we do that a lot.
Yes.
I've been guilty of that, to be honest with you.
Yeah, and that is something that I want to speak about, because there's a lot of spiritualism in St. Lucia. So persons, when they may see somebody who's hypoglycemic, for example, a person's blood sugar drops and they're diabetic, and they say that the person is having a spiritual attack. If they may see somebody with seizures, and they say that the person is having some kind of spiritual attack, or somebody starts to act out, even with hypoglycemia, but hypoglycemia does not always cause coma. So some persons, when their blood sugar drops, they become very, very agitated, and then the person would automatically be taken to a doctor or whatever. And if the blood sugar is not tested, then that person can receive a diagnosis of psychosis, which is not fair to the person, because that diagnosis then follows that person for the rest of their life. Yes, and it's one of the things that I'm very sensitive to, giving somebody a psychiatric diagnosis, because that changes everybody's lives. Because if somebody's diagnosed with schizophrenia, they then have to, even before, what would happen is that every time the person acts up, the family would automatically believe that it is the illness that is relapsing, and they need to be taken to hospital. Whereas persons with can get angry. So somebody with a psychiatric diagnosis some persons will tell you, I'm not allowed to get angry, because when I get angry, they take me to hospital. So that has its implications for the individual, and we have to be careful before we label somebody as having a psychiatric diagnosis. So
you're saying if we suspect anything untoward about another individual, family member, etc., the best thing to do is to take the person to a professional.
Yes.
Okay.
So in most areas of medicine, we do have concrete tests to confirm what's wrong, but psychiatry doesn't have a depression scan or an anxiety scan or anything like that. So the psychiatrist or the mental health professional knows that there are patterns, so patterns of thoughts, emotions, behaviors that fit an established diagnostic criteria. So for example, somebody with depression, a professional would know that there are 9 symptoms that they have to look at, and if the person has 5 of them, then it's highly suggested that the person has depression. And what I do, I give the person a rating scale to see how severe the depression is. So if the depression is severe and we have ruled out all other issues, then we can look at suggested treatment. Yeah? So the first step is seeing what is happening, what symptoms the person is presenting, then running tests, then running a severity scale to see how severe it is, and then speaking about treatment. So we can't get to the end stage before we rule out the physical causes.
I just thought I needed to ask you that question because we do that so often. We just, based on the person's behavior, we just assume the person is of unsound mind. We say things like, that girl is crazy or that guy is crazy, that sort of thing.
Yeah. And even a lot of persons, I hear them calling people zombie and that the person on cocaine and so on, and the people are not have never used cocaine in their lives but have a severe mental illness, and we label them with whatever labels that we would like. And I guess it boils down again to stigma, which we've dealt with here. So we have to be careful, and psychiatry requires a lot of humility and requires a lot of patience. A lot of doctors especially don't have that luxury of patience, especially if you're running a health center clinic and you have to see 50, 60 people for the morning. So you really don't have the time to sit down and allow somebody to speak about what their experience is like, to find out what the crux of the issue is. Yeah. So like I keep saying, we need to build our mental health services so that persons have more of that opportunity to be able to speak to somebody, to be able to vent, to be able to, and that the doctor themselves can get to the bottom of what is exactly happening and not make assumptions and then refer the person to a psychiatrist when they don't need to see a psychiatrist. I mean, I've seen so many persons in my practice who didn't need to come because that could have been dealt with at the GP level. And yeah, it's sad sometimes because a lot of those persons don't have the resources and they dip into their pockets and have to have that issue. So if we have to now look at the St. Lucia context and even our wider Caribbean, we have communities that are deeply spiritual and cultural. And that same culture can sometimes blur the lines between the medical, psychological, and the supernatural. So when someone starts hearing voices or behaving oddly, families often first suspect a spiritual attack or possession, and they may seek a church or other spiritual leader or herbalist, and sometimes that can offer comfort and maybe even heal the person. However, in a lot of the cases, what it does is that it delays necessary medical evaluation. Yeah. So by the time the person reaches the local psychiatrist or the hospital, then you have the illness has progressed, and the illness now becomes a lot more difficult to treat, and then a lot of persons become very fearful and agitated and frustrated, and you have the mental health system being blamed, that they're not treating the persons, they give them an injection that make them worse, these kinds of things coming out. But what happened is that they delayed the onset of treatment. The longer somebody with a mental illness remains without being treated, especially things like schizophrenia and bipolar disorder, the more difficult it becomes to treat that illness, and the worse the prognosis is for the future.
But Dr. Gilead, how do we know? Because if we're not allowed to judge people, when I say judge, determine on our own that this person has a mental issue, why should we worry if the person is acting strange? Let me give you a little story. There's a lady in Jamaica, and she's before the courts right now. Her name is Shimoya Green. And she, I think it was sometime last year, she had, I think she asked her boyfriend to have a discussion. And he said, okay, we'll talk later. And she apparently got angry. I think she had either 11-month-old or either a little older than that baby. She went up to the 3rd floor of the house and threw the baby off the balcony. Now the baby died. And she was arrested by Jamaica police, taken before the courts and so on. And she had some episode while she was in the courthouse. I think she began, what do they call this again when you fits? She had fits and so on. So the judge now said, hey, take this person for a mental evaluation. And when the results came out, it seems as though she had a problem for true, because they said now she's unfit to plead. So now they are recommending that she be taken, of course, for psychiatric treatment and so on. Now, imagine you're in that family and you have your suspicions, but you're not allowed to sort of call it out, right? I gather that's what you're saying. Let's not judge people and so on. So how would you know now that the Shimoya, in that particular case, they had a problem?
Yes, so you see, cases like this are very rare. And I'm sure from the hundreds of cases of persons who have committed infanticide, this may be the only one of that nature. So we cannot know, because we cannot foresee outliers. And from what I'm hearing you saying, she appears to be an outlier case. So she appears to be somebody who I don't think anybody could have known that her behavior was being caused by a fit. However, if she did have previous behaviors similar to that, and they were maybe cast aside and persons thought it was just part of her personality. So that's just the kind of person she is. She's always angry, she's always agitated, she acts very impulsively and so on. Then the family who's just saying that's just how she is, we have to ask, why couldn't they intervene and ask her or persuade her to see a mental health professional? How much mental health assistance is available in her community or in the area where she lives, and what may have happened with regards to the boyfriend before that could have taken her to that point where she throws her baby over from a building. And even after that, what may have happened with her, because remember I spoke about killing somebody can be a source of trauma for somebody. So killing your own child and then realizing, hey, I've killed my own child and I wasn't even of the awareness to know what I was doing. I lost myself. That can be deeply traumatic, and that may result in her now developing another illness, secondary illness, that may result in her being deemed unfit to plead. So it's a long, complicated story around that, and these kind of stories are very rare, and it's something persons have to understand. Persons with mental illness killing somebody else, that is very rare. It's not something that happens.
Especially your offspring.
Exactly. Yeah. So we have how many murders last year? How many of them were mentally ill persons? Maybe one, maybe two. You understand? So saying that mentally ill persons will commit an act of violence is unfair to the mentally ill person, because they are usually the ones who are victims of that. Yeah?
Yeah.
So back to the road that we were on, we also have to add resource challenges. So persons cannot always afford the tests. Yeah? you have limited access to brain imaging here in St. Lucia because it's very expensive to do a CT scan. Psychiatrists on the entire island, how many are there?
How many do we have in St. Lucia, by the way?
We have one who just went into the ministry, so she's no longer in practice. We have myself and Dr. Swami, and we have a child psychiatrist who also sees adult patients, and that's in the private sector. The public hospital, we have 2, and 1 psychiatrist in the community. So for a population of 180,000 people,
wow,
that is woefully inadequate, in my opinion.
So in terms of your practice, Dr. Gilead, do you have all the necessary tools and so on to...
Well, I do my best. I'm not perfect, so I do my best to keep myself as relevant as possible and to have as open conversations with persons as I possibly can. It is difficult sometimes because a lot of persons with mental illnesses, they have something called anosognosia. So in other words, they have poor insight into the illness. So they don't believe that anything is going on with them, that they're not having any difficulties, that everybody else is the problem, and that usually results in non-adherence with medications suggested, and persons not returning for the follow-ups and so on. So it's a complicated situation. However, what we're trying to do is to avoid the person. So when we get to that diagnosis, that we're sure that it's a psychiatric diagnosis, and we're not dealing with depression caused from an a steroid if the person has lupus, or from another medication. Antihypertensives can cause depression in case persons don't know that. So it's a lot of issues to look at when we're looking at psychiatric illness.
Let me just remind our listeners and viewers that you're listening to and watching on Facebook, YouTube, and also on X. Mind Matters with Dr. Julius Gilead, brought to you the compliments of Foresight Mental Health Solutions, located at the Tapio Hospital. If you'd like to call, you can call the fixed line at 572-9710. That's 572-9710. Or you can WhatsApp 287-0971. WhatsApp is 287-0971. Call these numbers at your convenience. I'll be looking out for your calls. Yes, Dr. Gilead?
Yeah, so if you have to look at, for example, a case, let's say you have a 30-year-old young lady who begins losing weight, struggling to sleep, feeling constantly on edge, and then her family says she has anxiety, and she's taken to a doctor at, let's say, at the health center, and she's prescribed antidepressants, but she gets worse. So she starts to tremble, her heart starts to race, she starts having panic attacks and so on. Later on, a simple blood test shows that she has high thyroid hormones in her blood, and her thyroid gland was overreactive. And what that does is that it floods the body with hormones that actually can mimic anxiety and panic. So once she's put on medications, all her symptoms disappear. So imagine if that person had remained on antidepressants for a year or 2 years, and that person would probably have gotten worse, and maybe would have experienced depression in addition to the anxiety, and may have ended up in a worse situation. Another case is maybe a 19-year-old university student or A-level student, let's say, or a Safa Lewis student, who starts hearing voices and acting paranoid. So they rush him to the hospital, and they suspect he has schizophrenia. But when questioned, he admits to having gone to a party and ingested a substance.
Sorry to disturb you, but you have a call.
I have a call. Okay, we can continue afterwards.
You have to use your headphones?
Yes.
Okay, this is Mind Matters with Dr. Julius Gilead.
Good morning, caller.
Yes, good morning, Andrew. Yeah, I'm just listening. But, Andrew, I heard you ask him a question and he didn't answer the question. Can you please answer the question you asked him?
What question?
I heard you ask him a question and he said to you, he's trying his best, but that's not what you asked him. You asked him if he's equipped. So, can you repeat the question so you can answer it? So I'm listening.
Thank you very much. Yes, I guess he felt that maybe you didn't answer it adequately.
Okay, so
Yes.
I'm, in case the caller doesn't know, I'm in private practice. I don't work with the public service. And yes, I do my best to equip myself as much as I can with what is available to me to make the most accurate diagnosis as I can. Does that answer your question?
He left already.
We left already. I hope it does answer his question. Yes. So yeah, so I was continuing to say that 19-year-old student, instead of being diagnosed with schizophrenia, after admitting that he used the substance, the diagnosis would shift from schizophrenia to substance-induced psychotic disorder. And that is something that once the substance is not used, after a few weeks, it does resolve. Now, what that suggests is that the person is at risk of developing a mental illness, and they would be advised not to use substances after that. So maybe with detox and counseling, the person would recover fully if they don't go back to using these kinds of substances. Another example is a middle-aged woman, for example, and I saw a case like that not too long ago, whose family believes she's developing dementia. So she's confused, withdrawn, forgetful, but it turns out that after the interview that she's severely depressed. So depression can mimic dementia, especially in middle-aged to elderly persons. And that's called pseudo-dementia. So what happens is that those persons tend to improve significantly with antidepressant medications, and the memory loss does disappear. A lot of persons don't realize that anxiety can cause memory loss. So some persons actually come to me and tell me that they have ADHD because they're not remembering and so on. When I probe into the history, that person has a long history of anxiety, and significant anxiety at that. And social anxiety, perfectionism, and all of those things, which can cause memory loss. So prolonged anxiety can cause significant memory loss, which can mimic ADHD symptoms. Yeah? Mm-hmm. So every symptom has a story, and we have to keep that in our mind.
What do you mean?
So every symptom has a story. So it's the person doesn't just start with a symptom. There is a story behind it, and we as doctors need to sit and have that kind of conversation. Ask about the childhood, ask about the family, ask about the grandmother, what the mother went through with the grandparents, this kind of stuff. Mm-hmm. Because misdiagnosis can be tragic. Yeah? So imagine being told that you have schizophrenia when your condition is actually epilepsy of the temporal lobes. And that's a condition that I don't know many people rule it out here in St. Lucia. But it is significant. I have seen a couple people in my practice with temporal lobe epilepsy who improve with epileptic medications and not with antipsychotic medications. Mm-hmm. Yeah? And even I mentioned that in the 60s and 70s, when everybody was traveling to the UK, there was a lot of diagnosis of schizophrenia in Caribbean migrants.
Really?
Yes. There was everybody was in a hospital in the UK with psychiatric illness, schizophrenia. So what one of the Jamaican psychiatrists did in that era was to carry out a study where they reevaluated a lot of those persons. And what they realized is that a lot of those persons did not actually have schizophrenia. It's that the British people actually did not understand the spiritual and cultural context, and so saw their symptoms as symptoms of psychosis. So those persons were incorrectly diagnosed and given medications and given that label, where they were treated differently by family, by work, by the society in general, and it caused a lot of devastation of the lives of those persons. So it's very sad for that to happen. Mm-hmm. Yeah.
Just a quick question going back to the Shamoya Green situation. Imagine if you're a family member, mm-hmm. You have a member of your family a stranger who has done what Shamoya Green did, okay? And it's determined that she has a mental problem. As a victim of that person's actions, it seems the courts now are saying, well, listen, you cannot put this person in a prison, right?
You can't.
Right. So what do you say? What do you say to the families of the victims in those situations who have to now sort of accept that the person now is not being incarcerated for something really bad that they did?
Yes, so the person may not be incarcerated, but I believe that the person would have to be adequately treated before they are released, because the court doesn't just release persons when they are not fit to plead. The court has its process. Yeah? So that person would have to, it had to be proven to the court that that person is not a danger to society when they go back out from wherever they're being held, whether it's a mental hospital or a general hospital, wherever, where they're being treated. They have to prove to the court, or somebody has to prove to the court, that the person is not a threat to society. So with regards to the family, I really don't know what to say to those persons, because it's very tragic, and I wouldn't want anybody to go through that situation. I really would empathize with them. Yeah.
Yeah.
But on the flip side, we have to sometimes look at that humanity. So that person who committed the act is human. The person who died from the act is also human. Yeah, that person who committed the act has a family as well, and I'm sure their family would as well be hurting, knowing that a family member of theirs committed such what they would consider a gruesome act. Yeah, so the shame involved with all of those things, the shame, maybe even the anger, because people like to find a cause or to blame somebody for their family member getting to that point. Yeah, and what I hear in a lot of those cases is that we had asked the police for help before and they didn't help, or we had asked this one for help and they didn't help, or there was a case around COVID where the guy said he wanted to go to the hospital, but then he couldn't go because they would have arrested him if they caught him out after curfew. Yeah, so there's a lot of, like I said, a lot of stories behind the event or diagnosis, and so it would really, I'm sure it would be very painful for the family, and they would have to trust the courts, because the courts have the processes before somebody is released from prison or from the treatment center.
So what would the life of this person, say the court deems them fit to be out in the public, what would their life look like? Say St. Lucia, what would that person's life look like?
Yeah, well, St. Lucia, unless persons know that person, then they would lead a normal life. Yeah. So unless everybody in society, wherever they walk, would say that's the person that killed whoever, then that person would lead a normal life where nobody would be aware of who they are, where they're going, where they're coming. But there would be things in place to ensure that that person does not have a relapse of the illness, or at least to minimize it. So the family would have to come on board. I believe there's a parole department now. There is social services. Everybody will be on board to ensure that person doesn't relapse into illness, or to minimize the risk of that happening.
Okay. So it's not just a simple case of, hey, we let you go.
No,
and
not that I know of.
Okay.
Yeah, the person.
Even in St. Lucia, we have these standards. Yeah.
Yes, even St. Lucia. Yeah, especially the family is always on board with the courts when somebody or case like that is being discussed, because somebody has to take responsibility of the person of ensuring that the person remains well.
So in St. Lucia, do we have anything for the case I just cited there, somebody who has committed a really grave crime and they have to go to some psychiatric facility and not to Bordelais? Do we have anything in place here in St. Lucia?
That's an ongoing battle. It's an ongoing battle between the court and the mental system in St. Lucia, the psychiatric system in St. Lucia. And I really don't want to go down that road because it's a long road. I think we have to wait to see what the two ministries are doing, because the two ministries need to collaborate. So the Ministry of Health and the Ministry of Legal Affairs need to collaborate to ensure that maybe a forensic psychiatric ward or some sort is set up, which must be manned adequately. So it's not just a ward that has nurses, but it has to be manned with a psychiatrist, one or two psychologists, social workers, not one social worker, but social workers, and the rest of the staff to ensure that persons remain well, that it's not too much of a disruptive atmosphere, and that the persons who go there receive adequate treatment and rehabilitation to ensure that their risk of violence when they are released is reduced or minimized.
Well, I know we're in the middle of the program, but I just want to say again, Dr. Gilead, I want to really thank you for bringing, mental health issues to the fore, because I don't think anybody else has done that.
Yeah, well,
so I want to say bravo to you.
It's my agenda. I always tell persons as long as it's to bring out my mental health agenda, I will do it. And
yes, and I'm so happy because now we'll have those of us who choose to listen will have a much deeper understanding of mental health issues and so on. Yeah?
Yeah.
Okay.
I'm hoping that the outcome of this program, because in our Caribbean society, the stigma is significant, and having a psychiatric diagnosis can actually isolate a person in our society. So because people whisper and people become hesitant where they see persons. Imagine employers and employees being hesitant when dealing with somebody with a mental illness. Families can hide their loved ones away, and it's just sad. Yeah, and that's why getting it right, getting the diagnosis right, is so important. Why it matters so much. Yeah.
If you're just tuning in, this is Mind Matters with Dr. Julius Gilead, heard and seen on Rev-Up St. Lucia every Wednesday from 10 a.m. to 11 a.m. Brought with the compliments of Foresight Mental Health Solutions located at Tapion Hospital.
Now, Andre, sometimes the opposite happens. People delay seeking help because they fear the label. So somebody may be having symptoms, and what I saw, especially in my training, was that a lot of young people especially may start to experience symptoms, and they do something called self-medication. So they smoke because the smoking calms them down and calms their mind, or they drink because the drinking causes disinhibition and they don't hide away as much, or they use other avenues to medicate their symptoms. And what that does is that it delays, again, treatment, and can result in a poorer prognosis when or if treatment is started. Persons are also very fearful of being admitted to a mental hospital, and I agree, because I wouldn't want to be admitted to the mental hospital we have here. Persons label it as all kinds of things, a horror house, and when I send persons or suggest that persons be admitted there, persons are horrified. Just this morning, somebody called.
You're talking about the Mental Wellness Center?
Mental Wellness Center.
Okay.
Just this morning, somebody was called me about their relative that's agitated. And I suggested that if the person is agitated, maybe they would be better served at the Mental Wellness Center, where they can be stabilized. And afterwards, I would be able to see them. And those persons are usually horrified to hear that suggestion being made. Maybe persons might even say, "How dare you ask me to take my family member there?" You understand? So it's the stigma around not just mental illness, but about the system itself.
And I imagine as well, Dr. Gilead, that the individual himself or herself don't even want to believe that they have.
There you go. So it's the anosognosia again. So a lot of persons with severe mental illness, that symptom is one of what we call one of the negative symptoms of the illness, especially schizophrenia. So one of the negative symptoms of schizophrenia is anosognosia. So I know in the olden days we used to have this saying that people who are mentally ill don't believe that they're mentally ill. Yeah, used to be said a different way. I don't want to use those words here, but that is true. Persons who do have mental illness, a majority of them don't believe they are ill, and that is because of that symptom. It is actually a symptom of the illness.
And it's not anything strange, because even those of us who are quote unquote normal, right? We don't want to even know we have a problem, maybe with high blood pressure or diabetes. We just don't want to know until, of course, it gets to a real crisis state, and then we seek help.
Yeah.
So I guess we're just human.
Yeah.
So whether it's a mental illness or some other thing, we just don't want to believe and accept that we have a problem.
Some persons believe and accept it, and some persons decide have the do it you are good dead mentality. So I have it, and whatever, I live my life as I want. If I die, I die. Whatever.
And as you said, they self-medicate.
Exactly.
Yeah.
And like I said, self-medication does not help. So it helps short term, but it does not help with the resolution.
Let me just ask you a quick question. If somebody really has a mental problem, whether or not they've admitted it, whether or not they've gone and sought help, right? And this person has a mental issue, and they, as you said, they decide to self-medicate and use some drug, whatever that drug may be, does that help the situation in any way?
No, it doesn't, because it can actually, the person may not need hospitalization when the symptoms start, but after they use the drug to self-medicate, then hospitalization becomes sometimes, most times, the only option, and that doesn't help. So I do not recommend that anybody who's experiencing symptoms self-medicate, because it can have its consequences which may not benefit that person. Yeah, we have to keep in mind that both delayed diagnosis, so delaying the diagnosis by self-medication has its costs, and the misdiagnosis or diagnosis somebody with anxiety when they have thyroid disease, all of those have its costs, their costs, the emotional costs, financial costs, societal costs that we may have to bear. So what we need is balance. And I was hearing that phrase in your last program. Balance. So an approach that's thorough, an approach that's compassionate, an approach that is evidence-based. I know a lot of persons would come to me and tell me, I had a fever and I went to the doctor and they gave me that. Did they do any tests? No. Did they, how long you spent with the person? 10 minutes. And that is unfair to the patient, because a fever might suggest a whole host of things that were not ruled out. They were just given antibiotics and fever medication and something and sent home. So we need to be more compassionate than that when we're dealing with persons who come to us as medical professionals. So investigation is important. And although some persons may not be able to afford the investigations, we still have to prescribe them. Yeah, we still have to recommend them.
So what about a scenario where somebody has a mental issue and they're not aware of it? Maybe even family not aware, because the person is acting quote-unquote normal, right? And this person, being unaware that they have a mental problem, would say smoke marijuana or drink alcohol on a regular basis. What are we looking at there now?
Yeah, well, I always say that substance use has, everybody who uses substances has their reason for using the substance. Nobody just decides to start using marijuana or start smoking marijuana, start drinking alcohol excessively. That person has a reason. So maybe the person finds themselves to be socially awkward, or finds themselves having a little difficulty talking to girls or talking to the guys on the block that they lime with, and so they may use the substance to try to fit in. So that person does have an issue, in that they may have self-esteem issues. So nobody just decides to start. So and that's the role of the psychiatrist or the psychologist, to try to find out what is driving the substance use, and how can that be treated. How can the person deal with those things without using substances? So,
I always thought that people smoke marijuana just for smoking marijuana, or drinking alcohol for just drinking alcohol's sake. You're saying there's something going on.
There's always something going on. So persons may not recognize it, but with a skilled professional who can delve behind their masks, that person can be pointed into that direction. A lot of persons say, I don't want to stop because I don't want to experience that. So they're making a choice. But that doesn't change the fact that there is something going on that's driving the substance use. Eventually, the substance use may become uncontrollable. So somebody who may start using alcohol to socialize, and eventually they find that it becomes out of hand because of stuff that happens in the brain as a result of regular alcohol use. The person then becomes addicted to the alcohol, and that is a different situation. But the initial use of the substance was driven by something that was going on.
So what if the person, as in the case of marijuana, is using it for religious purposes?
So so the person now wants to fit into a religious group and wants to ensure that they adhere to the practices and so on. So if they're using it in a religious group and they do develop psychiatric symptoms, then how does the religious group deal with those symptoms? Do they tell the person, you need to stop using to see if your symptoms disappear? Or do we take you to a psychiatrist? Or do we give you more and pray and hope it goes away? How do we deal with that?
So when somebody turns to either alcohol or marijuana because there's something going on, is it they are drawn to the alcohol or the marijuana based on the problem that they have, or it's just a decision that they make, I want to use marijuana or I want to use alcohol?
Yeah, well, it's not like a decision, I want to use this. It's about trial and error. So
whatever makes you feel better.
Right. So I see my friends using it, and I see the way that they maybe behave,
and maybe what they say about
exactly. And a lot of persons would use because they see their parent using it. So I see my parent using it, and I use it, and I feel a sense of power, a sense of calm, a sense of whatever it is that they get from it. They can hold a meds like a lot of persons say.
They can do it?
Hold a meds, so they can meditate adequately and reach a different realm where they can not be among the common man. Those kinds of words you hear persons saying, especially with marijuana use.
So in other words, say for example, I have my friends saying how they feel when they drink alcohol or when they smoke marijuana or whatever else, right? And I say, hey, maybe that could be good for me.
And you try it and it works, and then you try it again and it works, and you keep trying it, and eventually your brain decides, hey, this is a habit and I want you to continue it, and whenever you try to stop, it becomes like hell on earth for you.
Yes, you said that the last time, and I've been talking about that to my friends and so on. That was really revealing to say that when we start those things, we get on that bandwagon, and maybe sometimes we want to get off, and we can't, because the brain now, as you said, is saying, hey, listen, I need this thing.
And that's where the withdrawal symptoms come from, because the brain, the physical aspect of the brain has changed, where whenever we decrease or try to stop, the brain craves for it. And unless we don't surf those urges and allow ourselves to go through that painful period, the brain will continue what it's doing. The brain has to readjust.
And I guess here we are now, as people who don't know better keep saying, but he sees what that thing does to him when he drinks. He sees what happens, and he's still going back to it. Why is he going back to do something that he knows is harming him, harming his family?
So it's like persons who smoke cigarettes. To get off cigarettes, it's recommended that you do nicotine patches and other medications. What those things do is that the same receptors in the brain that the nicotine attaches to, they attach to it. So then the cravings are not as severe. Yeah, so it dulls the craving until the brain does the process of reducing the receptors, the number of receptors, and so on. But that again is a long process. I think a nicotine patch is usually over about 12 weeks or some either a month to 12 weeks. And stopping cigarette use is one of the worst experiences that persons can go through. I think it's even worse sometimes than trying to stop alcohol use. Although with the alcohol, they can experience withdrawal, psychosis, and those kinds of symptoms.
Does the same apply for one's love for sweets?
Yeah, well, it applies to any addiction that you have. Whether it be video games, whether it be sweets, whether it be women, whatever it is,
Mhm.
addiction that somebody has, then getting off of it is difficult.
So, with the little time that we have left, Dr. Gilliard, can you
I piqued your interest.
Yes. Can you explain? I mean, what happens in the brain that causes you now to want to crave something that you want to get off? I don't. What,
Andre,
how can that happen?
So you see, I guess I'll have to explain it again. So the brain of every human being has receptors for a chemical called dopamine, and there are other chemicals that have to do with pleasure.
When you say receptors,
Yes, receptors. So the brain cell, you have one brain cell connecting to another. So this brain cell is the one sending the signal to that one. Yeah? So to send the signal, it has to release chemicals into the little space between the two brain cells. Yeah? And that brain cell who's the one receiving has to have receptors. So when that one releases the chemical attaches to the receptors on the other one, and it causes the signal to continue. And that happens in a millisecond. Yeah? After the signal has continued, the receptor releases the chemical, and this cell reabsorbs it. And that continues constantly. So what happens is that if you have a substance that, for example, dopamine, and the substance you use causes increased dopamine in the space in between the two cells, there may not be enough receptors there. So that cell is telling the other one, hey, you don't have enough receptors, make more. Because I'm sending that amount of dopamine because you cannot stop firing because of all the dopamine, the stimulation I'm getting to give you dopamine. And so that other cell now creates more receptors. So the large amount of dopamine that's there gets taken up by more receptors, and so that one keeps on firing. Yeah? So when the substance is stopped, then that one is not getting dopamine from that one again. It wonders what's going on, and it tells that other one, hey, where the dopamine you were giving me, why it stopped? And that's where the cravings and the withdrawal comes in, because the discomfort that comes with that is tremendous. And what happens when the person uses again, dopamine again, and everything calms down. I'm sure you can speak to persons who tell you, I have to have a shot in the morning.
or 3 for the day.
So I have to have a shot in order to start my day. So those persons, that's what they experience. So they don't use for the night. In the morning they feel so restless and agitated. That's because the brain is asking for the dopamine, and they have to use to calm that down.
So I guess that would explain as well, Dr. Gilliard, the reason, for example, when we go to the gym and we that feel good.
That feel good, that's the dopamine.
Right.
And
I want to go back again to get more.
Yes. So the motivation to go back and all of those things, all of that has to tie in. Some persons may say, I want to go back, but may not be motivated, and that's possibly because the cell that's receiving has not made enough receptors to receive the dopamine, so they're still demotivated. Yeah. So all of that happens, and eventually, and that's why there's the motivation for persons to go drug seeking. I'm sure if you speak to the crack cocaine addicts, they spend all night sometimes using and seeking stuff, and they may go rob somebody or steal
their own parents,
right, to get money to use, and that's because of that situation that's happening in the brain.
That is amazing.
Yes. So it's not just that they are zombies and they have to use and they IAD2 and this kind of thing. Those persons have physical issues going on in their brains that prevent them or make it a lot more difficult for them to stop using the substances.
So to end on a positive note, if people are listening and we all have these things that we do to feel good, but it's making us miserable and we want to stop. But you're saying that is very, very difficult. Okay? So is there help?
Yes. Well, how much help do we have in St. Lucia? I know there is Turning Point. Outside of Turning Point, I don't know that there is much help.
And by the way, that applies for any of those addictions?
Any of those addictions. Turning Point can help because
wow.
It's about abstinence. Number one is the main thing there.
Because you even mentioned women a while ago.
Yeah, anything. So it's abstinence. So
And by the way, let's ensure we explain what you mean by women.
well, some persons have an addiction to sex or to
Right.
having women admire them, you could say. So I guess those persons will have underlying issues with trauma and so on that would have to be dealt with. But the main treatment of any addiction is abstinence. And together with that abstinence, if the person needs other medications to help them deal with the initial discomfort of the withdrawal from the substance, then that would be necessary. And focused counseling, focused and intense counseling. And afterwards, they would have to get into one of the AA or other programs which would help with maintaining them abstinent and dealing with any issues that may arise from them reusing the substance.
And I just want to repeat, it doesn't matter what the addiction is.
Yes, it doesn't matter what the addiction is. Although I don't know that Turning Point deals with sexual addictions.
I think some people are happy to hear that.
Andrew, you like too much drama, man.
so there's no help for me. No help for me. I might as well continue.
Oh, gosh.
Okay, we have to wrap up, Dr. Gilead.
Yes, so as we close today's episode, I want to bring the message home very clearly. So a psychiatric diagnosis is the last thing that we need to think about. It means that we must first rule out what it isn't before saying what it is. So it's a process that requires curiosity, humility, patience, three qualities often missing in modern healthcare systems that are under pressure. Yeah. So here in St. Lucia, we can strengthen that process by improving collaboration between GPs and mental health professionals. In my opinion, every hospital or clinic should have the capacity to screen for physical and psychological causes side by side, but we're not there yet. And we can also help by reducing stigma. And one of the reasons for this program is to help reduce stigma. So people feel safe seeking help early before the symptoms escalate. And as individuals, we can remind ourselves that mental illness doesn't make someone weak or mad, it makes them human. Yeah, someone navigating the complex interaction of biology, environment, emotion, that person, to be able to navigate all of that is significant, and those persons need as much support as they can get. Yeah? So next time you see somebody struggling, pause before judging, ask what might be happening beneath what I'm seeing, beneath the surface. Because every behavior, like I said, has its story. And until we understand that story, or at least hear it, sometimes we don't need to understand. Then until we do that, the diagnosis is not a label to give, but a journey that we have to take. So thank you for listening, and see you next week.
Thank you very much, Dr. Julius Gilead. Again, I just want to thank you for bringing this whole issue of mental illness to the fore. And thank you very much for bringing your vision to Rev-Up. We really do appreciate that. Thank you very much.
Very welcome, Andre.
You've been listening to and viewing Mind Matters with Dr. Julius Gilead, heard and seen on Rev-Up St. Lucia every Wednesday from 10 a.m. to 11 a.m. So join Dr. Gilead next week, Wednesday, same time, for another Mind Matters with the compliments of Foresight Mental Health Solutions located at Tapion Hospital. Well, this is the end of my stint here on Rev-Up St. Lucia for today, Wednesday, the 22nd of October. We have Kina. She'll be with you until 3 o'clock this afternoon. From 3 until 5 is going to be Zen the DJ. And from 5 until 6, we have Powell Politics. So do enjoy the rest of your day. Andre Paul saying so long.
Presents a program that puts your mental well-being first. Mind Matters. Hosted by Dr. Julius Gilead, St. Lucia's